Module 6, Cardiac. This recording will cover Chapter 30, Coordinating Care for Patients with Cardiac Disorders. We're starting off with coronary artery disease. So we're talking about the coronary arteries, the arteries of the heart that are feeding the heart muscle itself oxygen-rich blood. So the pathophys is going to be atherosclerosis, and that is going to occlude those coronary arteries, and it's going to cause ischemia. Patients may present with unstable angina, myocardial infarction, or even sudden cardiac death. Risk factors: cholesterol, hypertension, diabetes, obesity, smoking, and sedentary lifestyle. We know this. Non-modifiable, it can be gender, race, heredity, and age. So what is angina? Angina is chest pain or chest discomfort. We have stable and unstable. So stable means that the artery has plaque, it has narrowed, but they're fixed. It's just they're narrowed, but they're fixed. This type of chest pain discomfort occurs with physical activity, and it is predictable. So a patient can say, I'm going to go jog around the block. I'm probably going to get some chest pain. This is really important part of stable angina. It is alleviated with rest or meds. So the patient has this chest pain when they're jogging around the block. They stop, they rest, it goes away. Or they have the pain, they're running around the block, they stop, they rest, and they take nitrates, which is most likely going to be nitroglycerin, and then it goes away. So that is stable, and they don't need to call the doctor if this happens. It is not a medical emergency because they have either they rested and it went away, or the medication was taken and then it went away. So other symptoms that may accompany angina would be chest pressure, shortness of breath, fatigue, nausea, vomiting, diaphoresis, weakness, syncope, and epigastric discomfort. So a patient may say one or more of those other symptoms along with their angina. Unstable. So this is when this chest pain or discomfort occurs at rest. So maybe they were doing physical activity, but they took a break and the pain stayed. Or maybe they were having physical activity, they took the nitroglycerin, nothing helped. Maybe they weren't even doing any physical activity and it just came on its own. That is unstable, and that is a medical emergency. It is the first part of acute coronary syndrome, so it can lead to many, many other issues if left untreated. So first thing you want to do for any patient that presents with chest pain is to check their vital signs. If they have angina, they can also experience radiating pain that goes to the left arm, back, neck, and jaw. So one thing to know is not all chest pain is related to cardiac ischemia, meaning that it's not necessarily the heart that's causing this pain. It could be related to a dissection of an aneurysm, pericarditis, it can be the gallbladder, it can be pleuritic pain, pulmonary embolism, pneumonia, and GERD. So all of that has to be ruled out. But when somebody presents with chest pain, we were always considering it is a myocardial infarction. So how is this diagnosed? We are going to do a few different things. Labs, we're going to get a lipid profile, we're going to check our biomarkers. Remember, troponin is the gold standard. Our ECG, when the patient is having an angina episode, so if they're currently having chest pain, if we're able to get an EKG, it may show ST segment depression or inverted T waves, and that could mean that there has been some injury to the heart tissue. Or the patient may be normal after that angina subsides, so that is common also. An exercise stress test may be done when your blood work and your EKG comes back normal, but you're still having this chest pain. And if you remember what that exercise stress test is, it's a test that induces more work on the heart to try to see if you can get this to happen again so that we can record it. And then we have our coronary angiogram, also known as a left heart cath, which is the gold standard for diagnosis, which is done in the cath lab. So medications, we want to stop aggregation of blood components to the endothelium. That means we want to stop platelets from sticking to things that shouldn't stick in the inner lining of our vessels. And relief of symptoms. So we can't cure anything. We're trying to stop the progression and give the patient some comfort. if it is stable angina, the patient will likely get some type of antiplatelet like aspirin, nitroglycerin, which is a vasodilator, which is actually used during the chest pain, chest discomfort. And then, of course, we're going to give all those medications to reduce risk factors, so the blood pressure meds, blood sugar meds, cholesterol meds. If the patient is in the hospital, then they are likely to get oxygen if needed, aspirin, nitro, morphine, and some beta blockers, maybe some anticoagulants like a heparin drip, and calcium channel blockers. So when they go to the cath lab and an intervention is required, then they can put in stenting like here. They can put in like a roto-rooter to suck out stuff. It just depends on what it is, but that is common to put stents in. Patient may end up needing, if it is too much for the cath lab to handle, then they may need open heart surgery, which is known as CABG, coronary artery bypass graft. Okay, so lifestyle management, we already know this. Healthy body weight, diet, physical activity, stop smoking, check for depression, avoid alcohol, and cardiac rehab if the patient has had a CABG or open heart surgery. Complications can be MI, dysrhythmias, heart failure, and the assessments, we're going to do our typical HMP, vital signs, pain, our 12-lead EKG. We're going to assess if they are on any kind of recreational drug use, depression screen, and we're going to check those labs. We want to be familiar with the nurse's role after a PCI, so refer back to the original intro PowerPoint to this, and lots of teaching. Moving on to infective endocarditis, or IE. So endocarditis is an infection of the innermost layer of the heart, and it usually will affect the heart valves too. Whenever we say endo of the endocardium, we always include the valves. It's usually bacterial. So there are lots of risk factors for this one. So being older, being immunocompromised, IV drug use, diabetes, if you already have prosthetic heart valves, if you've already had endocarditis in the past, if you have some type of congenital heart defect, or if you have some type of central line catheter that is sitting in the heart, that is a port of entry and little pathogens can climb in there. So these pictures here, this is an echocardiogram, an ultrasound of the heart that revealed vegetation. So vegetation is like platelets and like white blood cells and debris and bacteria kind of all stuck together, and we call that vegetation when it's seen on an echo. So these little things can actually break off and travel and become a thrombus. So signs and symptoms of infective endocarditis. Osler's nodes, which are red and painful, Janeway lesions, splinter hemorrhage, murmur, fever, fatigue, and confusion, especially in older adults. Diagnosis, they're going to get blood cultures, an echocardiogram, and our labs will show increased WBC. So depending on how bad the damage is, they may require a valve repair or replacement, and then they are definitely going to be on IV antibiotics because we're talking about an infection in the heart, which is pretty severe. Complications, embolic events. So things can kind of break off and travel through the bloodstream and cause stroke. It can cause an MI, a PE. Other complications, heart failure, dysrhythmias. So our interventions, definitely give those antibiotics, make sure they always have IV access, give whatever meds for heart failure if indicated, provide social support, and if they are IV drug users, then refer them to counseling and community referrals. Teaching good oral hygiene, because that could also cause infection. The oral cavity full of bacteria just kind of goes down, makes its way to the heart. Make sure the provider knows the history and complete antibiotic regimen. So we have to be really careful. Next is myocarditis. So now we're talking about the myocardium, which is the muscle part of the heart. This is most common in males and young persons. It's the third leading cause of death in young athletes. So this is damage to the myocardium. It's usually caused by a virus, and it results in major heart dysfunction. So signs and symptoms: heart failure, cardiogenic shock, chest pain, dysrhythmia, dyspnea, palpitations, syncope. So the one that we're going to focus on, which is the viral type, can actually mimic the flu. So like fever, fatigue, loss of appetite, and maybe some muscle pain, like body cramps. So if you have myocarditis, you might think you just have like the flu. So many times people won't report it, they won't go seek help. So diagnosing wise, history, we can do labs, CRP, which is going to show inflammation, troponin and BMP, that's going to rule out myocardial infarction and heart failure. We're going to do 12-lead EKG, MRI, myocardial biopsy. So that's a heart biopsy. That's not done routinely. It really is for really bad cases, but that is the most definitive test to diagnose myocarditis. So treatment, we're pretty much treating whatever symptoms are presenting. So if they do go into heart failure, we're going to help with that, dysrhythmias, and possibly immunosuppressants if it's autoimmune. Complications, cardiomyopathy, heart failure, dysrhythmias, sudden cardiac death. Our assessments are going to be vital signs. It's an infection, so we might see some of those infectious signs and symptoms. We're going to monitor the cardiac rhythm. We're going to assess for heart failure, which is going to just think of fluid overload. Your interventions are really going to depend. Is it antiviral or maybe antimicrobial, possibly immunosuppressants? Really just depends on the cause. Provide emotional support, make sure the patient knows to complete all their medications, and they should avoid strenuous activities. We want the heart to rest. We don't want the heart to be overloaded. Next is pericarditis. So we're looking at the pericardium. It's inflamed. It could be infected by a virus, bacteria, fungus, or parasite. It could also be something like autoimmune or trauma related, or sometimes we don't know why it happens, it just happens. A lot of people have this, but they don't always seek help, so the numbers, the statistics aren't accurate. Signs and symptoms include pleuritic chest pain, that's like a sharp stabbing pain. And what is unique to pericarditis is that it's relieved by sitting up and leaning forward. So that also is going to be one of our interventions to keep our patients more comfortable, is to put them in that position. The patient may have new or worsening pericardial effusion. That's when fluid fills the sac around the heart. They can have some ECG changes on the monitor. They may even have a fever because this is an infection. Diagnosis, H&P, we're going to see those ECG changes, possibly ST elevations or PR depression. Chest x-ray will show an enlarged heart, but clear lung fields, but pericardial infusion could be present where there's that sac full of fluid. We're going to check our typical labs. This one will require blood transfusion, echocardiogram, CT of the heart, and MRI. So medications, we're going to have pain management, we're going to give aspirin, we're going to do anti-inflammatories. Complications is again pericardial infusion where that sac fills up with fluid. Our assessments, vital signs, we want to pay attention to the blood pressure, the temperature, pain. Remember, this one's special. They have chest pain, pleuritic pain that is relieved by sitting up and leaning forward. That is very specific to pericarditis. If we auscultate heart sounds, we will hear a friction rub. And then again, that ECG is going to show ST elevation or PR depression most of the time. So interventions, put them in a position that's going to help with pain and provide emotional support. With this one again, they should avoid strenuous activity. We don't want them overworking the heart. Valvular disease. So the patho on valvular disease is regurgitation and left or right-sided heart failure. Risk factors. Now we're talking about valves, problem with the valves. So risk factors include infectious diseases. We just talked about infective endocarditis, so that can damage valves. Rheumatic fever, myocardial infarction, heart failure, degenerative changes, pregnancy. So common valvular diseases include aortic stenosis and mitral regurgitation, improper closure of the valves. So our valves are supposed to be one-way valves. You know, they open and close. Sometimes they get stiff and then they don't open or they don't close as they should. Blood starts to backflow or leaks. Some of it leaks. So that is a problem with valvular disease. So most of the time, the first sign of valvular disease is auscultating or murmur. So that's why that's at the top. The patient may experience shortness of breath, dyspnea, orthopnea, crackles, angina, syncope, dysrhythmias, palpitations, fatigue, weight gain. If you notice, this sounds like a lot of our other signs and symptoms. So let's look at how this is diagnosed. It's going to be diagnosed through an echocardiogram, possibly a chest x-ray, cardiac cath, CT, and MRI. So that's why we have to rule out everything if a patient presents with anything cardiac, because there's so many overlapping signs and symptoms. So medications for this is going to include ACE inhibitors and diuretics. So the diuretics are going to hopefully prevent fluid overload, because if there's an issue with the valves and things getting backed up, if you have a lot of fluid in there, it's just going to make it worse. So we want to take some workload off of the heart. So the patient may need a mechanical or bioprosthetic valve, and this requires open heart surgery. And the prosthetic valve could be from a cow or a pig. So it could be a repair or an actual replacement. Now with valvular disease, when we're talking about surgical management with these repairs or replacement, this is what you need to focus on. Patient will have to be on lifelong anticoagulant therapy. They're always going to be on some type of blood thinner, and the patient needs to understand that. The patient may need a future valve replacement. Okay, so it's not a one and done. They likely are going to need another one in the future. They should have changes in their diet, including avoiding caffeine and alcohol. We also want to monitor for signs and symptoms of valve disease and heart failure. So they can get this replacement or repair, but they're always going to be at risk of issues with the valve. So they need to understand, they should be reporting edema or shortness of breath or weight gain, sudden weight gain, which could mean that they're retaining fluid. Complications include heart failure, cardiogenic shock, embolism, endocarditis, dysrhythmias. So our assessments are going to be pretty much the same as everything else. Vital signs, pain. They're going to be on a cardiac monitor. We're going to do a neurovascular assessment. We're also going to do respiratory assessment, because we know that those valves can cause fluid to back up, and we'll hear wet lungs like crackles, pulmonary congestion. This could also lead to activity intolerance. We want to listen to the heart sounds. We want to make sure we get daily weights and the patient does daily weights at home. And if the patient is on warfarin, we're going to monitor their INR. So interventions, we're going to give oxygen if they need it, and of course we're going to give them their medications. They should be on a sodium and fluid restriction as well. So teaching, lifelong anticoagulants. Consider prophylactic antibiotics, especially when they're having a dental procedure. Strict adherence to coagulation and bleeding precautions. And next we have our intro to heart failure. So with heart failure, there is myocardial cell dysfunction. So the actual myocardium, those cells are dysfunctional. This is going to result in the inability of the heart to meet needs of the body. So the body, the cells, tissues, and organs, they need oxygenated blood. So with heart failure, the heart just isn't able to get the blood out so that the body can function. This can be acute or chronic, but it is progressive and it will worsen over time. Risk factors include CAD, hypertension, diabetes, metabolic syndrome, obesity, smoking, and high sodium diet. So these are all the things, same things we've been talking about since we started this, can also lead to heart failure. So signs and symptoms are going to depend on what type of heart failure it is, when did it start, and how severe it's gotten. So generally speaking, the patient will experience fatigue, weight gain, tachycardia, low or high blood pressure, murmurs, and extra heart sounds, S3 and S4. So for our purposes, let's talk about the difference between left and right sided heart failure. So with this, you have to remember the blood flow of the heart. So if you have right-sided heart failure, where does the blood come from on the right-hand side of the heart? It is coming from our superior and inferior vena cava. So if your right side of the heart, if that right ventricle is so weak and it can't push out the blood how it should, then the blood is just going to sit there and it's still going to keep pouring on in from the body, but there's really no place to go. It's going to get pressurized and it's going to back up where it came from, which is the body. So you're going to see peripheral edema. You're going to see possibly ascites with that fluid kind of just collecting in the abdomen. You're going to see JVD, jugular vein distension, and hepatomegaly on imaging, so a enlarged liver, versus the left-sided heart failure. So the left ventricle, where is that blood coming from? It's coming from the lungs. It just got reoxygenated. It's coming to the left side of the heart, and after that, it's supposed to go systemic, right? It's supposed to be pushed through the aorta and then to the body. So if the left side, if that left ventricle is weak and it just cannot push anything out, then it's going to get backed up, and it's going to get backed up into the lungs. So with left-sided heart failure, you are 100% going to see issues with the respiratory system, the lungs, shortness of breath, trouble lying flat. You can hear crackles with your stethoscope. You can have weak pulses, cool temperature in extremities, fatigue, weakness. Now, on a real patient, it can end up with a mix of these signs and symptoms because humans are not textbook. But for our purposes, we are separating it strictly from left to right. So you should definitely know right side rest of body, left side lungs. Okay, so your responsibilities as the RN is to monitor fluid status. That is a big one. With heart failure, we're thinking fluid overload, fluid getting backed up because it can't go past the heart. We're going to monitor I's and O's. We're going to monitor daily weights. The patient should weigh themselves at home and report weight gain. Patient may be on a food restriction. It just depends on where they're at in the disease. Low sodium diet for sure. And we want to educate them on taking their medications and signs and symptoms of an exacerbation, because that will usually require hospitalization, and reducing workload of the heart. With heart failure, the heart is weak, so if you're giving it strenuous activity, it's going to become weaker and weaker, and we don't want that. So a lot of education for your patient. Okay, and this is just a little picture, again, showing the difference between left-sided heart failure and right-sided heart failure. And that is the end of this recording.